Hello, hello. How exciting is this? Can you feel it in the air? Can you feel it? You can feel the buzzing, right? There's like a buzzing. Do you guys remember the television show Cheers, where everybody knows your name? Okay. Well, here at the IWMF Ed Forum, everybody knows your IgM count. So instead of Sam, the bartender, we get Rockstar Docs. And it feels like one big Walden family. So whether you are here in the room in person or whether you are joining us virtually, welcome to your WM home. We're really glad that you're here and that you can join us. I'm Lisa Wise, Vice Chair of Information and Support at the IWMF. And I am absolutely thrilled to introduce Dr. Mary Kwok, Clinical Associate Professor at the University of Washington, here to help us understand WM basics. Now, I have lived with WM for the past 14 years, and I know personally that the basics never get old. Picasso said, "I'm always doing that which I cannot do in order that I may learn how to do it." And that describes how I feel every time I review all my blood work. And I try to remember exactly what each of those darn numbers mean. It can be super confusing. Who better to help us learn the foundations than Dr. Kwok, a renowned educator who was honored with the 2019 Military Treatment Facility Teacher of the Year Award. In her own words, "I love being a teammate to parents. What you'll find in me is an advocate. I want to understand what's important to you and help you reach those goals." And here's a fun fact. Dr. Kwok enjoys spending time in her garden, explaining it is just amazing to see plants grow from tiny seedlings and yield a harvest. There are so many life lessons that come from our garden, and I love being out there with my kids. Dr. Kwok, I want to invite you up to the stage and thank you for walking us through the garden of WM basics this morning. We couldn't ask for a better guide, teacher, teammate, and patient advocate. We're grateful for your wisdom, and we can't wait to learn. Folks, I just want to say that if time permits at the end, we're going to take some audience questions. So there are microphones here in each aisle. And for our virtual attendees, you do not have to have FOMO. Please post your questions to the Q&A section. And Dr. Kwok, we cannot wait to hear from you today.
Thank you so much. Thank you, Lisa, for that kind introduction. And for everybody here, as someone who's from the local area, I just wanted to welcome you to a beautiful Seattle day. The mountain is out. I hope you get a chance to enjoy some of that. Today, this morning, I'll be going over just the basics. This will be like Waldenstrom's 101, like it was just described just a second ago. For some of you, this is going to be review. For some of you, this is going to be all new. So we'll take questions at the end, and hopefully you could follow along with the handouts that are there. So let's get started. I thought that I would start out with a couple of cases of patients with Waldenstrom's to introduce this talk. So the first case is actually a farmer. The farmer had no significant personal medical history or family history, and initially actually presented with pain in the shoulders and in the wrist. This farmer, though, had severe nosebleeds, and the severe nosebleeds were so bad to the point that this patient had anemia. They made the nosebleeds go away, transfused blood, but then he came back another year later with the same symptoms, joint pains and severe nosebleeds. Same symptomatic treatment, and he went back, but came back to the doctor 5 years later, this time with pneumonia, swelling of the feet, rash on the trunk, and his urine had protein. So the protein was albumin, but not what we know as Bence-Jones proteinuria, which is a protein that we find in patients that have multiple myeloma. He also had enlarged lymph nodes that were biopsied, and after the biopsy, he bled from the wound, as it was described, for more than a fortnight. That still didn't lead a diagnosis, and he came back 2 years later with severe abdominal pain and still had protein in the urine. He had an ocular exam, so an eye exam that showed he had a lot of bleeding, so what we would call retinal hemorrhages, and still had symptoms of gingival bleeding and nosebleeds. I'm going to present the second case as well. The second case is another farmer. This farmer also had no past medical history, this patient's past medical history was notable for left eye trauma that was 13 years prior, but no family history, but now was presenting with decreasing vision in his right eye, to the point that he was no longer able to read. He also had bleeding from the nose and from the gingiva, and he had enlargement of the lymph nodes in the neck and under the mandible. He was also admitted for bleeding and felt better after his transfusions. Those symptoms were addressed, and he came back 2 years later with some symptoms of fatigue, gingival, nasal bleeding, and a bone marrow biopsy. Apparently at this time, a sternal biopsy, if you can imagine, was attempted, but a sample was not obtained, and he bled for over 12 hours from that sternal marrow biopsy. His labs were notable for anemia, and he also had low platelets. So the way that these two cases were described was that these two patients seemed to suffer from the same issue, the same malady as it was described. Both were anemic, both had tendency to bleed, both had slight enlargement of the lymph nodes, and they were both anemic, although the anemia didn't seem to be due to hemolysis, which is breakage of red blood cells. And when they did the bone marrow biopsy, they found that there were chiefly what they called lymphocytoid cells, so cells that looked kind of like lymph cells. They did have plasma cells that were seen, but it was at the upper limit of normal. Nothing really that looked outright like a condition that they thought they were treating or finding called multiple myeloma. And I present these two cases because these are the two cases that were described by Dr. I think it's Jan Waldenstrom, maybe Jan Waldenstrom, who's a Swedish physician who actually coined the term Waldenstrom macroglobulinemia. And if you think about these two patients that presented with the vision change and the bleeding and the enlargement of lymph nodes, you may or may not recognize some of these symptoms within the things that led to your own diagnosis or that you've heard described in Waldenstrom's. Usually it takes more than just two patients to describe a disorder, but somehow Dr. Waldenstrom was very, very astute and described this condition. And so we'll talk more about it today. So I just wanted to go over the incidence and epidemiology of WM and also the precursor condition, IgM-MGUS, what are the risk factors. We'll talk about how it's diagnosed, how it's staged, who needs treatment, and then what if you don't need treatment. So the first thing that I wanted to talk about is what is Waldenstrom's macroglobulinemia? And so earlier was described, it is a type of non-Hodgkin lymphoma, but it's characterized by two things. The finding of what we call a lymphoplasmacytic lymphoma in the bone marrow. And so I just highlighted a picture here of the lymphatic system because lymph nodes that we can feel, like these patients described, might be in the neck or in the axilla or something, but there's lymph nodes actually throughout the whole body. And you can actually find these lymphoma cells in the bone marrow on a bone marrow biopsy. But then the blood also shows an IgM monoclonal gammopathy. Waldenstrom's is preceded by a precursor condition that's called IgM-MGUS, and MGUS stands for monoclonal gammopathy of undetermined significance. And when somebody actually does have Waldenstrom's, it can be either symptomatic or asymptomatic at the time of initial diagnosis. So what do we know about the incidence of WM? So just for historical context, like I showed you, it was first described in 1944, but it wasn't until 1988 that it actually became reportable in the US as a malignancy. And then the International Workshop for WM first met in 2000. And so history tells us, I think, that there's a lot of progress that's being made, and probably the longer we know about it, the more we find it. But it's still rare. The incidence is about 3 in a million patients, with about 1,000 to 1,500 cases diagnosed in the US per year. And currently, if you combine LPL and Waldenstrom, so LPL would be lymphoplasmacytic lymphoma that's non-IgM, altogether they make up only 2% of newly diagnosed non-Hodgkin lymphoma in the US. The question that frequently I receive when somebody's first diagnosed with WM or even IgM MGUS is, where did it come from? And why do I have this, right? So I just wanted to talk about some of the risk factors. So we know that the incidence of WM and IgM MGUS increases with older age. White race or ethnicity seems to be a risk factor for this. And we also know that males are more commonly affected than females at a ratio of about 2 to 1. There's some thought that maybe chronic immune stimulation might play a role. So this comes from data from the VA where it showed that hepatitis C or HIV might actually be a risk factor for WM, or having autoimmune conditions increases the risk. And then for some, if there's a family history, that might also be a risk factor, because clustering of Waldenstroms has been observed for over 60 years. So we know that patients that have relatives with WM or B-cell malignancies or IgM MGUS tend to cluster together. And there's a 64% increased risk for developing WM or LPL in individuals that have a first-degree relative. So then the next question then becomes, should I get my whole family screened, right? So the short answer is no, but the reason for that is because only about 4% of patients with WM actually have a positive family history of lymphoplasmacytic lymphoma or WM. And the first-degree relatives of WM have a 20 times higher incidence of WM, but it's still rare overall. And so currently there's no rule for screening of asymptomatic relatives, and currently there are no preventative measures, but maybe one day, but currently that's the case. I just wanted to share some graphs, if you're more of a visual person, that shows the incidence rates of WM and LPL in the US. So the blue bars in the graph represent male patients, and the orange represent female patients. And as you can see, regardless of your ethnicity, across the board, it's more common in males than females. And it's more common in the white Americans versus Black, Native American, Asian, or Hispanic, but it can be found in all demographics. This is another graph showing the incidence of WM and LPL in the US based on race, but also based on age. And so what you can see is that prior to the age of like the 40s, when people are in their 30s, it's very, very, very uncommon. But as patients age and go into the 80s, which is at the far right of the graph, you can see that it's much more common, much more higher incidence. This is also showing that the incidence is highest in white Americans, lowest in Black Americans, but can be seen across the board. Outside the US, there's actually a lot of data as well showing the incidence of WM coming from the US, but also in Sweden, and Japan, Taiwan, and South Korea, showing that these numbers actually reflect the demographic differences that we see in the US, where the incidences are higher in actually northern Sweden, even compared to southern Sweden, I think, and then present in Asia, but not as high. I wanted to talk about IgM MGUS because a lot of people might actually present initially with IgM MGUS before they're diagnosed with WM. And IgM MGUS is actually not uncommon. It's found in about 1 in 600 persons over the age of 50. So it's 3 times more common than WM. It's more common in the elderly, and most people will not go on to progress onto WM or another disorder. They will just stay with their IgM MGUS. But because it is a precursor condition, patients that have IgM MGUS require lifelong monitoring. This is just a graph to show you how we might risk stratify somebody that has IgM MGUS. And some of the labs we follow in MGUS are different from the labs we follow in WM. So we might follow the free light chain ratio and the M spike. These are not necessarily numbers that are checked all the time in WM, where we rely more on just the whole IgM itself. But if somebody has an abnormal kappa lambda ratio and an elevated M spike, we think that their risk for progression to an symptomatic condition, usually a non-Hodgkin lymphoma like Waldenstrom's, is higher. That being said, so that's the lower number. That's the lower number, the lower red graph here. But as you can see, most people with IgM MGUS do not progress prior to dying of another natural cause. So I wanted to go on and talk about the diagnosis, like how is Waldenstrom's diagnosed? And so there are a lot of different parts to the workup for somebody that has a new diagnosis of WM, which can feel really busy. But I'll try to break it down to make it more digestible. So frequently we'll start out with simple labs. And most of this is blood work, although we do sometimes check urine tests. And so for the labs, for your initial diagnosis, we usually check a CBC, which stands for complete blood count. This gives us a sense if somebody's anemic or has low platelets. We'll check chemistries to look at kidney function, but also look at other organ function. We'll check IgM levels, but also other immunoglobulin levels like IgG and IgA. We'll check an SPEP. This is what gives us that M spike or monoclonal spike that I was mentioning. Immunofixation that tells us what kind of protein is being found. Free light chains. And then something called a urine protein electrophoresis, frequently done on a 24-hour urine sample. Those are necessary for the diagnosis of WM, but for prognosis, we'll also check markers called a beta-2 microglobulin and LDH, which helps us look at that as well. A bone marrow biopsy is part of our typical workup for somebody that has WM. First of all, it helps us diagnose the LPL. And specifically, what we're looking for is, are there LPL cells in there, and do they follow the typical pattern that we see in patients with LPL specifically? But it'll also give us the quantification of how much of the marrow is involved. So most patients with Waldenstrom's don't necessarily have a tumor that'll show up on a scan. And so it gives us, by describing the percentage of bone marrow involvement, it gives us a sense for, is there a lot of tumor cells or is there a little? Is it 10% of bone marrow involvement or is it 90%? On the bone marrow biopsy, we can also do molecular studies. So you might hear these terms like MYD88 or MYD88, CXCR4, TP53 mutations are some that are commonly looked for on the bone marrow biopsy. And lastly, we'll do imaging. So frequently, in terms of the imaging, we're doing a CT scan of the chest, abdomen, and pelvis. And the whole idea is to look for the lymph nodes that you can't feel. So we have the lymph nodes that we can feel and the lymph nodes internal that we can't feel. So we're trying to see if those are enlarged or if the spleen is enlarged. And then there are a whole bunch of other tests that may be done. They might not be done all the time, and some of these might be done only based on symptoms. But measurements of what we call serum viscosity, which we'll touch on in just a moment, an eye exam, testing to look for breakage of the red blood cells, increased risk for bleeding, amyloid. About 1% of the time, patients that have IgM proteins are going to have myeloma and not Waldenstrom's, and so we're looking for that. And then we may do additional like viral screening if we're planning to do therapy with rituximab, or brain or spine imaging, specifically if there are any neurological symptoms. And so if you have an IgM monoclonal gammopathy of any concentration and bone marrow infiltration by these small lymphocytes that show this pattern, that would lead to a diagnosis of Waldenstrom's. So based on the percentage of the LPL cells that are found on the bone marrow biopsy, if that percentage is less than 10% and there's an IgM spike that is low, we call that MGUS. If it's 10% or more, any IgM level, then the next question is, are there any symptoms? Is there anemia? Is there low platelets? Is there enlargement of lymph nodes or what we call hyperviscosity symptoms? If the answer is no, we call that asymptomatic WM and we typically observe. But if there are symptoms, then that would be an indication for treatment. I want to touch really quickly on the MYD88L265P mutation. I know they're talking about it probably in the other session right now, but it's seen in about 90% of patients with WM. Sometimes the numbers are quoted as a little bit higher, and it's something that we can find in patients with WM and also in patients with its precursor condition in IgM MGUS. As a clinician, it's helpful because it helps us understand if we expect a response to BTK inhibitor therapy. Doesn't seem to impact what we call chemoimmunotherapy, like, for instance, bendamustine and rituximab, or BCL2 inhibitor therapy. And then the impact on survival is debated. For patients that don't have it, what we call wild type, it seems to be associated with a higher risk for transformation to an aggressive lymphoma. And patients that have MYD88 wild type tend to have a shorter time from smoldering to active disease. For patients that do have asymptomatic or smoldering WM, you'll hear it called both ways. These are patients that you fulfill the diagnostic criteria for WM but don't have any symptoms related to WM. And many patients with asymptomatic WM may not require therapy for long periods of time. So if you're diagnosed with asymptomatic WM, about 6% of patients will go on to need treatment the first year, about 40% at 3 years, and about 65% at 10 years. But you see that still there's 35% of patients at 10 years that don't require treatment. So it'll vary. One of the tools that I like to use with my patients comes from the Dana-Farber. There's a website where you can go in. It's a research tool, and there's like a disclaimer on the site, but I find it helpful to kind of help visualize what we think somebody's risk is for developing WM, just using the percentage of bone marrow infiltration, IgM level, beta-2 microglobulin, and albumin. Developing WM that needs treatment. So for patients that are on observation, this can sometimes be a little frustrating or maybe, just kind of waiting. But at the same time, it's not a bad thing because it's very possible to go on observation and being monitored with watch and wait for a long time. Typically, when we're using this strategy, we're monitoring patients with blood counts, IgM levels, chemistries, and then monitoring symptoms. Imaging can be done, weighing the risks and benefits, though, of the risks with imaging, like exposure to radiation and contrast or whatever. And so that discussion can be had with the treating oncologist. So I want to touch on the symptoms because if you are on a watch and wait strategy, or even if you're newly diagnosed, the symptoms are really important to recognize in WM. And so the three main categories that I like to break up the symptoms, at least when I think about it, are sometimes there's symptoms that are due to just having too much IgM, what we call hyperviscosity syndrome. But sometimes the symptoms are just because there's too many LPL cells. And so we call this due to tumor mass or actually infiltration of the bone marrow. And then lastly, sometimes, even though there might not be a ton of IgM or a ton of marrow involvement, the IgM is causing symptoms that require treatment. And those are just directly related to the IgM itself. So I just wanted to break it down into these three different categories. So this first one is called hyperviscosity syndrome. And I put this image up here of viscosity, these kind of thickening of the liquid, and in this case it's your blood, right? And hyperviscosity occurs because this IgM protein, which is represented by this green, what we call a pentamer, is what the shape of IgM looks like in the blood. It's not like a small protein like a lot of these typical antibodies are. And so if you have a lot of IgM circulating in the system, it can make the blood flow, it can impact the blood flow. And these symptoms are because there's shear forces that rupture venous channels. So it interrupts blood flow within your veins. And what happens when you have too much IgM is they can lead to the symptoms of nosebleeds and gingival bleeding. Because it affects the very, very small blood vessels in your body, it can cause visual changes where you have very small blood vessels in the eyes, and then cause symptoms within the brain like dizziness, lightheadedness, fatigue, or sudden hearing changes. When there are these types of symptoms and the IgM level is high, we think of that as hyperviscosity syndrome. I want to go back because there is a lab that we could check called the serum viscosity level, which is sometimes very helpful for us to support a diagnosis of hyperviscosity. But I would say one of the limitations of checking a serum viscosity is that it takes a long time for the lab to result, almost past the time where we need to actually know what's going on. So very frequently, hyperviscosity syndrome is a clinical diagnosis. We can do something about it when it happens. And so there's a procedure called plasma exchange, and essentially it temporizes hyperviscosity by removing the IgM from the blood. So this is one kind of visual of it, where a patient is hooked up to a machine. There are two access points, one that removes the blood and sends it to the machine where the excess IgM is removed, and then another access point where the blood is returned to the patient after that. And the whole point of plasmapheresis is to relieve hyperviscosity symptoms. And the idea is to bring the IgM down to relieve those symptoms, and sometimes we'll prophylactically do plasmapheresis or plasma exchange prior to planned rituximab, because sometimes with rituximab we can expect a flare of IgM. Sometimes a single plasma exchange is sufficient. Sometimes people need it two, or maybe even more times. But remember, all this does is artificially remove the IgM. It doesn't turn off the spigot where the IgM is actually being produced. So the other set of symptoms are actually due to tumor mass or infiltration. And so what does this mean? This means that maybe there are so many LPL cells in the bone marrow that it's inhibiting normal production of blood cells. So this can lead to low blood counts. Sometimes there can be enlargement of lymph nodes, and these can lead to what we call constitutional symptoms. These are kind of like vague symptoms that your doctors are probably always asking you about, like, are you losing weight? Are you fatigued? Are you having fevers? Not because you say have the flu, but just kind of fevers all the time, or night sweats, especially the kind that make you like change your pajamas at night or need to change the sheets at night. Sometimes these cells can actually infiltrate the central nervous system. So it could actually infiltrate the brain and the spinal cord, causing a syndrome called Bing-Neal syndrome, which is quite rare. Or maybe it can cause the lymph nodes to become so enlarged that it's starting to cause symptoms. For instance, like if you had a lymph node that was enlarged near the kidney that was then pushing and blocking off the drainage of your kidney, the urine in your kidney. Or maybe the spleen is so enlarged that it's making it that you have no appetite, Those are all symptoms that we look for related to the Waldenstroms or the LPL. When the spleen is enlarged, it can also start trapping your blood cells so that it can drive somebody to become anemic or have low platelet counts. And then the last category are symptoms that are related to the IgM itself. So not having too much IgM, that's hyperviscosity syndrome, but the IgM as an antibody that's causing direct effects. And so there are a lot of different kind of rare conditions that are associated with this, but things that we do know about, right? So cryoglobulinemia is one, cold agglutinin disease, what we call light chain deposition, amyloidosis, neuropathy, or even IgM deposition disease itself. This is a picture of cold agglutinin disease. This is when the IgM antibodies, they cause direct effect on the surface of the red blood cells. And so on your areas of your body that are colder, right? So your limbs and things like that, what you can get is you can get a rash. And then as these IgMs attach to the red blood cells, it can lead to breakage of the red blood cells, what we call hemolysis. Or cryoglobulinemia. Again, cryoglobulinemia is also like cold related, and the type 1 type of cryoglobulinemia is associated with WM, and it can cause skin changes with hemorrhage. It can lead to issues with rash and scabbing of the skin. And then what we call the IgM monoclonal gammopathies of clinical significance. So I mentioned some of these already, but there are neuropathies, there are bleeding syndromes, and things like this. And so when we think that these syndromes are due to IgM, that's actually an indication to consider treatment for the IgM. So the question is then, how do you treat it? And I think that'll be addressed in other sessions here. But I would say currently, if somebody is newly diagnosed with WM, our two big categories of treatment include what we call chemoimmunotherapy. So this would be bendamustine and rituximab as a very common approach, or targeted agents like BTK inhibitors and other agents that will be discussed at this meeting. So I finished a little early, but I just wanted to kind of wrap up, right? That WM is diagnosed when there's a clonal IgM population and bone marrow infiltration by a lymphoplasmacytic lymphoma, which is a type of non-Hodgkin lymphoma. Having those two things together, we call WM. WM is preceded by IgM MGUS, but not everybody that's diagnosed with WM have findings that require treatment. A lot of patients can be followed with watch and wait. Symptoms, though, that do require treatment in WM are due to symptoms related to hyperviscosity, tumor mass or infiltration, or direct effects from the IgM itself. I just wanted to end with a special thanks to the IWMF for advocacy and education and everything they're doing to move this field forward, to the many WM researchers, to the patients, especially those who participate in clinical trials, and then to the families who are living, to patients and families who are living with WM and allow us to participate in care. So, thank you.
Thank you so much, Dr. Kwok. That was wonderful, very eye-opening and really richly informative. I just want to invite folks to come up to the microphones to ask your questions. So come line up, and we would love to hear them. And is it okay if I start off with my own question
please.
for you?
Yeah,
is that
thank
okay?
you.
What is your favorite piece of wisdom that you wish every WM patient knew? If there was one thing you could tell every global WM patient, what would it be? And take a minute. It's my favorite rock star question, but I know it puts you on the spot.
Oh, yeah. It's hard to limit it to just one thing.
Okay, pick three.
Okay. Well, the first thing is I usually share the WM website and support group information because I think there's a lot that we cover, but I'm not actually sure how much soaks in during the first visit, which is where we review a lot of this. But I also find that patients with WM quickly become experts in WM, and I think it's through things like educational things like this that are in advocacy and support groups that are put out. The other thing, I guess, that I always want patients with WM to know is like the symptoms to look out for. And I think sometimes it's very, very easy to attribute any new symptom to WM. And of course, we want to make sure that we look for that. But many of these symptoms that people experience once they're diagnosed with WM don't necessarily mean chemo's starting soon, right? And so during the watch and wait period, especially, when there's no chemotherapy on, that's a great time to be aware, but also to like live life. I don't know. This field is changing so much. Even since I started seeing WM patients, the landscape of drugs has really changed a lot, including targeted therapies. When I was a trainee at Walter Reed, I remember Steve Trion coming to visit us, and we were doing bortezomib, dexamethasone, and rituximab as how we treated patients. And so much has changed since then, right? And so I would just encourage people to keep that in mind. Yeah.
Thank you. That's so helpful. And I love that you said in between live in those watch and wait moments, because with the WMers that I speak with around the world, one of the questions I get the most from newly diagnosed and others is, how in the world do you carry this diagnosis and also carry joy and all of the meaningfulness in life and everything you want to do with your family without having to worry? And how do you hold both of those truths at the same time? So I feel like you just wrote us a prescription that when you can go and enjoy life, go and enjoy life and don't be burdened by the diagnosis. And I'm really grateful to you. I see we have a brave questioner. If anybody is hesitant to come up to a microphone, you can see, I love microphones. Write something down on a piece of paper, give it to me, and I'll ask your question for you.
Hello, Dr. Kwok. As you know, I've had chemotherapy, and my numbers remain very good and steady, but I do see my blood reports every 4 months, and I wonder about some of the things that I see. Mostly they stay the same, but I see that the MGUS is rising. So what does that mean?
Is the IgM is increasing?
Not the IgM, the MGUS.
Oh, the M spike.
M spike.
Yeah,
sorry.
Yeah. That's a good question. So I think when we think of MGUS, or we think of like the M spike, and we see that increasing, that makes us think that maybe things are not necessarily steady, but progressing, right? Like slowly increasing. Sometimes it's helpful to look at the rate of how quickly things are increasing, meaning like if it's like by 0.1 maybe each time you're having it checked, versus like if the numbers are doubling, right? Between visits, like those are two very different scenarios. And so sometimes I think the rate would be helpful to look at. For WM itself, we're, like in MGUS we use the M spike, but in WM we tend to use the IgM, right? And the total IgM, which includes the M spike, but also just normal non-monoclonal IgM in that number. And I think if symptoms are going to come out, they're going to come out based on the total IgM numbers, at least for hyperviscosity syndrome. So maybe keep an eye on the numbers and the rate of increase. At the same time, like in between visits, sometimes the numbers can go up.
They fluctuate.
They can fluctuate. Oh yeah, they can fluctuate, especially after like vaccines and things like that. That's just your normal immune system, right, going up, but usually tends to come down. But sometimes the numbers may go up predictably and kind of take off, and so do pay attention to symptoms. Yeah.
Okay, thank you.
Thank you.
Good morning. You mentioned in response to one question that for patients that seem to be asymptomatic in the sense that it shows up on their blood test, but they're not necessarily feeling different, is that you tell them certain symptoms to look out for. I wonder if you could list the certain symptoms that you ask patients to look out for.
Yeah. That's a great question. So we usually review the symptoms of hyperviscosity, right? So any vision changes, hearing changes, unusual bleeding. Sometimes this is more vague, but like dizziness or fogginess can sometimes be described and if we can correlate that with high levels of IgM, then that would make us concerned that it's related. There are certainly like other reasons people have these types of symptoms. Symptoms of anemia include things like fatigue or shortness of breath. And then if people tell me that they have symptoms that, don't really make sense, like unexpected weight loss, things like that, they certainly get our attention.
The statistics of occurrence that you showed the graphs, I've always been curious about the confidence, especially as a woman, that you have in those. Is there a chance, and have people studied this, is there a chance that that's simply a measure of the disparity of medical care?
Oh, like it's not being diagnosed?
Exactly.
Yeah.
I mean, the symptoms seem so broad.
Yeah. I think that's really possible. Some of this data, it comes from like the Mayo Clinic. They were following the MGUS patients within like Olmsted County in Rochester, Minnesota. And so there, it's probably a representative sample, assuming, I actually don't know if it's representative, but I think that they're covering a large amount of patients. And then I think another interesting database that is, I haven't seen anything specifically published in the WM space, but the Icelandic researchers have this study called the iStop-MM study where I think they looked at maybe 75,000 Icelandic patients born before 1975, where they're screening everybody that is willing with SPEP and, essentially looking for monoclonal gammopathies. I mean, they're a predominantly white population, and so I'm not sure that it'll translate across the board, but I think it would be interesting to see what comes out of there, because inevitably, if they're doing SPEPs, they're going to detect IgM monoclonal spikes. So maybe one day we'll get better data, but I hear your concern for sure.
I'm just curious, where does peripheral neuropathy fit into everything you've been telling us?
Yeah, that's a great question. So neuropathy is super common with Waldenstrom's patients, and it can be directly related to the IgM itself. We know that there are some antibodies we could check for, like the anti-MAG antibody or anti-glycoprotein antibodies that are detectable in the blood, but sometimes we can't find those things. I think that if somebody has anti-MAG antibodies and they have an IgM kappa monoclonal protein, it fits really nicely. If somebody has a lambda, they can have what we call POEM syndrome. And so we look for different things, but we don't always find it. And then sometimes people could just have neuropathy related to the WM itself without antibodies. I think that's something that we usually get our neurologist involved. And sometimes, although this sounds really painful, an EMG can be really helpful because it'll show us different patterns of why somebody has neuropathy. It'll help us understand if the neuropathy is more related to, say, like underlying diabetes or something, or maybe something compressing in the back versus like direct damage to the covering of the nerves that we call demyelination.
So if, with regard to that last, does axonal peripheral neuropathy, is that unlikely to be Waldenstrom's related?
So, yeah, I think that when we see like these direct attacks on the nerves, they tend to be what we call demyelinating in terms of the pattern. If we see axonal, then we have to kind of keep a broader perspective in terms of what's causing the neuropathy.
Okay, thank you.
Thank you, Dr. Kwok, for your presentation. I really enjoyed it. I noticed that you distinguished between WM and LPL. I still don't quite understand that difference, so would you explain that a little bit in more detail?
Yeah, so LPL is probably like the big, broad term, and WM is when somebody has LPL with an IgM monoclonal antibody. There are people that have LPL, but it might be, say, IgG or IgA, or what we call light chain only. And so those graphs that I showed you distinguish between people that had IgM LPL, which is Waldenstrom's, or non-IgM LPL. I think that makes sense.
Okay. Hi, Dr. Kwok. Thank you for tackling that whole idea of when to get treated. And I'll just give you an example of myself. Back in 2017, going for just my normal exams, and the doctor did the CBC and noticed my hemoglobin was lower, and then I had it retested, and then I was sent to hematologist, and then they found out in doing the other tests the IgM was like in the 2000s, and then had the bone marrow biopsy, and they found the MYD88. So it turned out that I was in watch and wait from that particular time until last year. And that was the crucial time in discussions with my oncologist. I was experiencing like some nosebleeds, real fatigue. The IgM had gone up to like 6,900. And I said, you know, I've been going to the IWMF conferences and finding this is the time where we have to really look at what's happening. So we agreed that zanubrutinib would be a good next step. So since that time, and that would have been June of 2023, the IgM level had gone down to the 2000s, all right? The M spiked down to 1.5, the red blood cells increased, the hemoglobin increased, hematocrit. My energy level, I said, I can't remember when I felt really this alive. Now, it seems it's sort of staying there at that point. And so I was wondering, is that what you can kind of expect? It kind of tapers off after a while. I'm taking the same amount, 320 milligrams.
So your question is, things have stabilized down, but they haven't gone down to normal
Right.
levels. Yeah, I think that's actually quite common. If you look at the studies where WM therapies are used, very, very rarely do we see what we call complete responses, where the numbers go all the way to normal levels and the M spike goes away and the marrow is negative. But that's okay, I think even if we get to a complete response, unfortunately, we don't think it's a cure, and patients that achieve better numbers with control of symptoms and control of IgM will do fine, even if the numbers are outside of normal range. And so I would say that's great. You've achieved the goal that we're looking for. It doesn't mean that we won't try to make it better or to make it completely go away and, with future therapies or whatever. But I think that's the experience of many, many people.
Okay,
Yeah.
thank you.
Hi. I have some questions about the IgM flare. I'd like you to define it for us in a little more specific terms.
Sure.
If there are other ways other than plasmapheresis to prevent it or to treat it, and also if there is an IgM flare, what are the treatments for that condition?
So that's a great question. So I actually experienced this firsthand when the first ECOG studies for rituximab came out, because the IgM flare seems to be associated with rituximab, and it tends to occur, probably when the tumor burden is greatest. So we worry about it most in the very, very beginning as we treat somebody. And the concern is that, say you're starting out with an IgM of like 4,000 or 5,000 or even 6,000 where you're needing treatment, and introducing rituximab. And what was observed was that the IgM numbers went up after rituximab before coming down. And that is a flare. Having the IgM numbers go up and flaring in and of itself is not a big problem unless it causes symptoms of hyperviscosity, which, it can cause, like the case, vision loss or something, which would be very, very devastating. And so the idea is always to try to prevent that from happening. So one strategy would be, for instance, if you're planning to do bendamustine and rituximab treatment, maybe for cycle 1, until you could get the disease under a little bit better control, you omit the rituximab and just do bendamustine for cycle 1 and introduce the Rituxan cycle 2. Or maybe you bring the IgM levels down using plasmapheresis, because that buys you a couple of weeks before the IgM will naturally go back up again, to give you enough buffer if there is a flare that there won't be symptoms, like devastating symptoms.
And how is it treated if it does flare and it does start showing?
Oh, plasmapheresis. Yeah, removal of the
that's-
IgM.
Oh, I
Yeah,
see.
yeah.
So that is what's done. Okay. And are there any other, does it ever occur with BTK inhibitors that there's a flare?
I don't think so. Yeah, I don't think
Okay,
so.
so it's really, really associated with rituximab? Mm-hmm. Okay. Thank you.
Yeah.
We have just a few minutes left and a couple, we've got a lot of online question. So I'm hoping we can power through here together so we can ask a couple for our virtual folks.
Is it okay if I ask?
Yeah,
General?
I'm
Okay,
behind you.
okay. I'm watch and wait for 6 years, and I was looking at your chart number 18, trying to see if I could figure out what the risk of progression is after 6 years. Okay?
Yeah. I don't know. I think that it would probably be a variety of things to look at in terms of what are your numbers and how have they changed, what is your bone marrow plasma cell percentage, et cetera. No changes. Then I would say that I wouldn't be surprised if you went another 6 years or even longer without any, needing any therapy. But I would say, that's the whole purpose of watch and wait is, I could say this, but I could be totally wrong. And so ongoing monitoring is probably the right thing to do, just like you're doing. Yeah.
Okay.
Yeah.
Thank you, Dr. Kwok, for your presentation. I had a question about being diagnosed with WM as well as multiple myeloma. What labs do I need to follow if they're seeing both?
Oh, okay. That's a really good question. So IgM multiple myeloma is very, very, very rare. I think I've seen 2 cases. It's just very, very rare. Multiple myeloma, the cancer cells in multiple myeloma are called plasma cells. So when you do a bone marrow biopsy, primarily you'll see plasma cells without what we call lymphoplasmacytic lymphoma cells. And WM is honestly a different condition, right? Where it behaves more like a lymphoma. So just to touch on the symptoms associated with myeloma. So myeloma, these plasma cells, they form antibodies and they tend to manifest clinically in a few different ways. One, it can also cause anemia, which is similar to WM, but it can cause kidney problems, typically associated with elevation of light chains. And it can also cause what we call lytic bone lesions, like bony destruction, directly related to the myeloma cells or plasma cells themselves. So those are the symptoms to look out for WM. I actually don't know if anybody has both. I tend to think of them as 2 totally separate conditions. I don't know.
Thank you, Dr. Kwok. We have a ton of questions virtually that came in, but unfortunately unable to answer every single one of them. But I did just want to pick out a couple, if in 2 minutes we can maybe roll those in. Some patients and doctors say IgM has to be in the thousands, where there are many with IgM under 1,000 who are symptomatic. So can you speak to IgM levels and their relationship to symptoms?
Yeah, so I think for IgM levels causing hyperviscosity, it's very, very uncommon to have hyperviscosity symptoms when the IgM's less than 4,000. But it doesn't mean the IgM can't cause symptoms, right? That's that last category where the IgM itself is an antibody that's causing symptoms. And so that's very, very possible. It can cause anemia through things like cold agglutinin disease or Macroglobulinemia. It can cause neuropathy or other symptoms that do require treatment.
Okay, super helpful. And because you said anemia, for WM anemia, is it necessarily low hemoglobin or can it be low ferritin?
Ooh, okay. So
Trick question
we'll
at the
cover
end.
this on Sunday, actually. But so low ferritin essentially suggests somebody's iron deficient, right? And so iron deficiency can be seen for a variety of reasons. Like most commonly in the U.S., it's due to GI bleeding, and it always makes us screen for colon cancer. Or in a premenopausal woman, it could be menstrual blood loss, or those are probably the most common things. For whatever reason, I think it's 3% of patients with WM will actually present with iron deficiency, and it totally has to do with the way the iron is controlled in the body that seems to be affected. A protein called hepcidin is affected in patients with WM that causes iron deficiency, so that your body can't move the iron. And so that would be one possible manifestation of WM.
Ooh, but that's a nice plug for the anemia
Yay,
breakout. So that, to be continued, right? That's
Right,
the segue. Thank you so much for that. Like I said, I've had WM for 14 years, and you just finally explained LPL to me. I finally understand it. I can't believe it. That's like amazing. So a whole bunch of light bulbs went off here just listening to you teach. And it's
you.
very clear why you won the Teacher of the Year award. So we're so grateful to you. Please join me in giving a round of applause to Dr. Kwok.
Thank you.